4, 3, 2, and 1. Good evening, everyone. We welcome you all to Ortho TV. This is in association with MOA Masterclass Webinars on Trauma. To introduce today's topic and speaker, I hand over to our President, Professor Dr. Ajit Shinde.
Good evening, dear friends. On behalf of Maharashtra Orthopaedic Association, I welcome you all for second episode of MOA Masterclass Series. Also, we are celebrated 30th MOA Day, and just now we have completed the spiritual program. Total 9 programs we did from 1st May till today, and today's webinar is the 10th activity of MOA week. MOA Association is formed on 1st May 1983. It is the 38th anniversary and foundation day, and there are more than 2,000 members. After this spiritual lecture, now I am entering in the karma, and our karma is a academic activity, and already we have discussed in last Sunday on the fracture neck femur, and today we are going to discuss fracture dislocation acetabula. We have excellent panel today, brimming with stalwarts in the field. Our President-elect Dr. Gadegone sir is the convener, and my friend Dr. Pradeep Kothadia is a coordinator. I welcome our faculty members, Dr. Tanna sir, Dr. Sen sir, my friend Dr. Mahesh Kulkarni, and Dr. Atul Patil. And the case presenters are Dr. Lokhande, Dr. Shinde, and Dr. Mahesh Kulkarni. All are renowned in this field. I hope they will do the show up to the mark, and we will come to see all variety of the trauma in this particular issue. I think Dr. Karmarkar is not going to attend. I read he is here. Okay. My best wishes to today's webinar, and I hand over to our convener, Dr. Gadegone, for further proceeding.
Sure. Thank you, Shinde sir, for your brief introduction. Now, at the outset, I must thank Dr. Kothadia, Neeraj Bijlani, and Ashok Sham for kind help for organizing this wonderful webinar on the fracture dislocation of the hip joint. Now, I selected, along with the Shinde sir's cooperation and Kothadia, a best faculty out of all in Maharashtra, and we have also invited a guest faculty, none other than Ramesh Sen. Ramesh Sen needs no introduction because now he is a president-elect, Indian Orthopaedic Association, and well-known name in the Acetabular Surgery and surgery of avascular necrosis, which is a very untouched part in the world, not only in India, but all over the world, hip preservation. So, next speaker is our Dr. Tanna sir. He also doesn't need any introduction. He is our master of masters, and he will guide us in many aspects of the fracture dislocation. Dr. Mahesh Kulkarni is here. Dr. Atul Patil is from Pune. They are all young stalwarts. They are working in the acetabular surgery. And those who are presenting cases, they are Nitin Kimat from Nagpur. He is also dealing with acetabular surgery. Dr. Vijayananda Lokhande from Pune. He is also doing hip surgery, and he is an arthroscopy surgeon also. Milind Joshi and Tanvi Shinde. I hope this will be eye-opening recent advances in the management of the fracture dislocation. And recently, you must be knowing And to the all viewers, I am telling that the Ramesh Sen has published a paper on the topic which he is today presenting, and therefore it should be one of the main attraction of this webinar. And I appeal to all that you must listen to what are the views on recent management of his talk. Dr. Kothadia, please go ahead. Thank you very much.
Thank you, Dr. Gadegone. Now I'll start rolling the ball. The first lecture of mine, I'll share the screen, is on the mainly posterior fracture dislocations of the, just a minute. Wow, I want a full screen slideshow. How we can get a slideshow? Yes. Yeah, I welcome you all, everyone, faculties, friends, and delegates to attend this MOA Masterclass on the fractures or dislocation of the hips. And it's me who is going to start the very absolutely common topic, that is a posterior fracture dislocation of the hip. This is the most common injuries. Almost 25 to 30% of the acetabular fractures are mainly the posterior acetabular injuries. And I think many of us are routine orthopedic surgeons, many of our colleagues know how to approach from the posteriorly for total hips and other surgeries of fracture neck femur. So I think from my point of view, every orthopedic surgeon should know how to manage this injury, as these are simple, but you have to take some of the points into consideration. Dear friends, I have a protocol how I manage this injury. I will just enumerate these protocols in detail, how to manage. So these are my 10 commandments to treat this posterior fracture dislocation of the hips. The first commandment is the diagnosis. This is very obvious. It's a fracture with a dislocation, a fractured posterior wall with a fracture dislocation of the hip, which is very obvious. But here it is a subtle dislocation. We feel there is a dislocation, and here the posterior wall is also missing. If you see the posterior wall line which is missing, so we call it a subtle dislocation. So it has to be taken that you must realize this is also dislocated. The second point, once you see a dislocation, it has been taught to us that dislocation needs an absolutely emergency close reduction as early as possible to prevent the head going into a vascular necrosis. If you are not getting close reduction, by close means don't hesitate to go ahead and do open reductions. I'll let you know what are the indications of open reduction. And if you have done the close reduction, it must be followed by a test of stability under anesthesia when you are tackling the fracture dislocations posteriorly. So about the stability of the hip, there are two schools of thoughts. Somebody believes the stability of the hip does not depend on the size of the wall fragment. Some believe it depends upon the size of the wall fragment. They say if it is the size of the fragment is less than 20%, it is stable. If it is more than 40%, it is unstable. If it is between 20 to 40%, it is called as undetermined stability. It's very difficult. But to me, every fracture dislocation hip after reduction needs a stability test under anesthesia. What are the requisites? How we do the test? Fluoroscopy is a must. Usually the obturator oblique view. The hip has to be in 90 degrees of flexion and 20 degrees of adduction, and give an axial load, a little axial load. And while doing that, you have to keep on observing the C-arm. What result you should see, whether the hip subluxate, or if you see in the C-arm, there is an increase in the medial joint space. That means it is an unstable hip that needs to be tackled very well. As I told you, when you need an emergency open reductions, you sometimes need an open reduction as an emergency. Irreducible dislocation. What could be the causes? They are either in intra-articular wall fragment. You can see this wall fragment, which is intra-articular. It is not allowing hip to go, becoming a concentric hip. It is getting dislocated. So it is irreducible dislocation. Sometimes the soft tissue goes inside. In one of my case, the whole of the external rotatress went into the acetabulum, not allowing the head to come into the acetabulum. There is sometimes a sciatic nerve entrapment. In one of my case, this is a fracture dislocation with the posterior wall. You can see the posterior wall which is here, and the sciatic nerve was trapped between the wall fragment and the fracture and the acetabulum, and the patient was howling with the pain. That is the area where you have to go ahead and do a open reduction as early as possible. After close reduction, we need to have a CT scan. Why we need a CT scan? To know the fracture geometry. The CT scan is very important. There are certain features we must know. We must know whether it is only a wall, and if it is a wall, whether it is a single fragment, as you see here, or it's a combination, as you see here. On your pre-operative planning, everything depends. You can definitely plan how you are going to proceed further. Then you see whether it is only a column or like this, or it is a column with wall. The whole strategy of treatment changes from all fracture to fracture. That you also need a CT scan to see for the marginal impaction. In posterior fracture dislocations, 25% people get a marginal impaction, which has to be tackled very well, because that is the most weight-bearing portion of the acetabulum. Some CT scan shows the head indentation also. That's where you can definitely know what is the prognosis of that hip, and you can explain it to the patients. Also, CT scan is needed to see the picture, where Dr. Ramesh Sen is going to talk to us regarding the Pipkin's fracture. Here you see the wall, here you see the margin. In this CT, you see all three criteria: wall, Pipkin's, as well as marginal impaction. Some important considerations: identification and location of fragment. You must know where are the fragments located. If they are high up in the dome like this, then you may need a trochanteric osteotomy. If they are like this and you have to do a trochanteric osteotomy, fix the dome fragment and then interfragment fixation with plating. Or if it is the inferiorly, you have to just release the J-max and get the reduction and fix the fracture accordingly. So these are the important considerations. Regarding approach, you only KL approach is advised for all posterior acetabulum injuries. It is supposed to be the workhouse for the posterior acetabulum injuries. Some operative tips: during surgery, we need a manual or a femoral distractor assisted distraction of the joint. Why we need it? We need this distraction for removal of the loose fragments or a wall fragment from the joint, and you can give a very good lavage of the joint, clear off the complete acetabulum very well. This is a loose fragment I have removed from the acetabulum after doing a distraction. So this is needed when you are doing the surgery. We must take some precaution during surgery when you are doing KL approach. During surgery, the hip should be extended and the knee should be flexed to protect the sciatic nerve from stretch palsy. This is the way you have to have your position, the hip to be in extension, the knee in the flexion, to reduce the tension on the sciatic nerve. Thus, to me, I always protect the sciatic nerve with my fingers. I retract sciatic nerve with my finger. I use sciatic nerve retractor. They are available. Some people are in habit of using that, but I never use that. I use my fingers for retraction of sciatic nerve. Now, when you are doing this, keep soft tissue attachments of all the fracture fragments. Don't remove them. See for marginal impaction as well as head indentation. You may see head indentation. If there is a head indentation, it is a bad. It's likely to go into avian. But to know the vascularity on the head, we do drilling of the head with 3mm drills and see whether the blood is gushing through it. If it is gushing, that means there is a vascularity. The head is chance of head becoming viability is more. Marginal impaction, how you tackle the marginal impaction? This is a marginal impaction. You can see on your left-hand side. On the right-hand side, there is a femoral head. What do you start? Use a curved osteotome and you just push it underneath this impaction. This is the osteotome which is putting in, and just turn the osteotome. The head acts as a template. The whole fragment has to be turned onto the head of the femur, so that after turning, you can fix this with a temporary K-wire. And once you fix with the temporary K-wire, there is a void above the impacted fragment. That void has to be filled with a bone graft or a bone substitute. And after that, you can go ahead with the fixation of the fragments. Marginal impaction, this you see very well in the preoperative film, which has been taken care of the way I described you. It has been elevated, fixed with a bone graft, cancellous bone graft from the trochanter, and it is fixed with a plate. So in case, another situation where you have to take consideration whether it is a column or wall. How you tackle? This is a case where it is a column and a wall. You can see very well, both the things are fractured, posterior column and wall. So always, it's a dictum. You reduce the column first, fix the column first, and then align the wall fragment, and then fix the wall fragment with the plate. So that is, and always that you should do a reduction of the column first and extension. Now getting a reduction of a column is a very difficult. So when you're reducing a column, you have to put a shank pin into the tuberosity, derotate the column, get the reduction, and once you get the reduction, hold the reduction either with jungle boot clamp or a pointed reduction forceps as a temporary measure, and then start fixation of this. Once you do a reduction, then you go ahead with a definitive fixation. In definitive fixation, if the wall fragment is a large fragment, you can use an interfragmentary, but always neutralize with a plate. If it is a combination, then you have to use a spring plate. These various spring plates are available commercially, but they are very expensive. This is the way I do a spring plate on table. I take a reconstruction plate, cut the terminal portion holes of that reconstruction plate, and turn the distal prongs, the cut end of that plate with a plier at a 90 degrees. This is the way you can get very well a spring plate. And that spring plate, this is the spring plate which is turned up, and this plate we hold onto the wall and the commuter fragments we fix. After fixation, always neutralization plate is a must for after fixation. Next step is when you are putting implants and screws, you should not go into the joint. You must take precautions regarding preventing of intra-articular hardware, as well as how your plate and the screws should go. What I do, I usually put a drill in the direction of the craterosciatic notch. Then I take out a drill bit, put a smaller size K-wire, move the hip in all directions. If the wire is intra-articular, the wire moves. If it is not intra-articular, it doesn't move. That's the way I test whether it is intra-articular or not. Then I pass the screw in that direction, in the direction of craterosciatic notch, which is a very strong bone. You get a very good hold. So this is the way you must take a precaution when you're doing intra-articular fixation. Once your fixation is over, then you have to do a meticulous closure, copious lavage, and copious lavage, proper debridement with excision of devitalized dead muscles which are post-traumatic, maybe due because of traction, because of retraction. Soft tissues have to be taken out, and I use a post-operative indomethacin to prevent HO, because chances of HO are very high in posterior. If you do proper debridement, the chances of HO are less. Post-operative rehabilitation, I do immediate non-weight bearing hip exercises and mobilize the patient as early as possible. There is always a controversy. Some people would like to give a low dose irradiation to prevent HO, but I don't do that. And a total weight bearing is usually advised after 8 to 10 weeks, depending upon the fixation. So dear friends, my 10 commandments I diagnose in a proper way. Reduction has to be done if it is dislocation with a test of stability. Post-reduction CT, for all posterior acetabular injuries, we do a KL approach. We must know what is the location of fracture. Depending upon you decide whether you need a trochanteric osteotomy or you don't need it. Some of the operatives, which I already told you, reduction methods using a shank pin into the ischial tuberosity to derotate the posterior column. temporary fixations of the fractures with K wires and definitive fixations depending on the fracture geometry, meticulous closure and proper post-rehabilitation. That gives a very good results. There are some recent things which are coming up. The 3D prosthetic models. You give 2D CT images to a machine which gives a 3D plastic models for you. They are very extremely important for to know the geometry of the fracture, to counter the plates after reduction. This way you can reduce the time on table. Nowadays people are coming towards the Gibson approach if the fracture fragment is too high, or extended iliofemoral approaches. Nowadays, antegrade or retrograde posterior column screws, either percutaneous or after opening one approach, you put another column by using percutaneous fixations, and the custom made plates are available nowadays, which there is no need to counter the plates when you are doing surgery. So thank you for your patient sharing. I will now.
Yes, sir, excellent presentation. And now,
thank you.
Faculty can ask the question to the Kothadia, sir. Sir, namaskar, sir. Tanna, sir, namaskar. So, Kothadia, sir, to start with, primary reduction, what is the time period you will attend?
Reduction as soon as early possible. There is no, if you see a dislocation, it should be done as early as possible.
But suppose the patient comes after 10 days, will you attempt for a close reduction?
See, in that case, I will just get everything ready, even for open reduction. I will try close reduction. If not getting, I will go ahead and do open reduction immediately.
Up to what period of time you will try to do a close reduction? What is the up to 2 weeks?
Ideally, it should be within 3 to 4 days. You will be able to get good reduction. After that, the soft tissue starts contracting, and it is very difficult to get a close reduction.
It is better
even on table after, they say after 10, 15. It is better to explore.
But do you think the immediate reduction is really required for the AVN avoidance, or you feel it is only for the future comfort of the surgery?
It is one thing. It has been in the literature. They says if you do an immediate reduction, there are chances that the stretching of the vessels are less, and you get a chance of AVN are less. And second thing, as you said, yes, comfort surgery is also after doing reduction.
Because do you feel the AVN depends upon the reduction? What I am asking is the AVN probably is decided at the time of accident. Would you agree to that? You wouldn't agree to that.
Yeah, it is decided at the time of, depending upon the fracture, it is decided. But it is always better that you should do a close reduction as early as possible.
Yes, you want to say something, Ramesh?
Yes, sir. I just wanted to say it is partly maybe at the time of injury, but it is this posterior dislocation with an abnormal rotation of the hip due to that dislocation, which leads to a stretch on the inferior vascular bundle, which is going from front to back. And longer it stays in that position, higher are the chances of AVN. And that is what we take. Why we take it 6 weeks or 12 weeks, 6 hours or 12 hours? This because if it is a prolonged ischemia, which can be relieved by reduction of the dislocation, we can reduce the chances of AVN. So by 6 hours, right now, what we have seen in our cases is the difference is 12 hours. If we do within 12 hours, the AVN chances are less. If it's more than 12 hours, the chance of AVN are more. Now, if, as you said rightly, that what is decided in injury, if it is a pure dislocation, the chances are higher. And if it is a fracture dislocation, the chances are lower because the amount of rotational deformity and the amount of stretch is less in a fracture dislocation than in a pure dislocation. So there are both the factors which play into it.
I presume, I am not aware of the literature, I presume it is available that early dislocation reduction can reduce the chances of AVN. Is there any real study about it?
Yes, sir. There are studies also, and I think we can get enough evidence for that.
Because we always say it is all hearsay by the experts talking about it. Is there any real evidence of that?
Yes,
that's what I am asking.
Yes, sir.
Because why I am saying is, as Dr. Gadegone mentioned, if the patient has come after 8 years, 8 days and 10 days, that means 100% he is going to go for AVN, then there is no point in reconstructing. You got to do
No,
the
sir.
replacement.
No, sir, it is not like that. It depends on the relative dislocation. I think we remember, and at least you are from the time when we used to say regular dislocation and irregular dislocation. And why it was said was because the amount of a dislocation, it is the positional stretch which happens to the vascular bundle. If that position is that and it's locked in that position, the stretch is there. If it is an irregular dislocation, what we used to call in old Kedas books and all that, then you don't have that kind of a stretch. And these are the cases. I have seen cases even 6 months late who did not get any AVN. So it's not always that the delay will be responsible, but if you look at the literature, it is there that 6 hours or 12 hours are important. Most of the literature initially used to say 6 hours. What we found was it is 12 hours. Yes.
Then a basic corollary of that is, in a younger patient, even if he has come after 10, 15 days,
Yes.
it is worth reducing it, keeping the head, reconstructing it, and
Yes,
take
sir.
your chance, because
Yes, sir.
AVN may occur, may not occur.
Yes, sir.
What I'm
Absolutely
trying to
right.
say.
Absolutely right.
Okay, now I think I will request Professor Sen just to give his presentation on Pipkin's fractures.
So I hope it is visible.
Yes.
So
Yes, it is very much visible.
thank you. So I'll be talking about a femur head fracture. We have got specific things to see in a femur head fracture, whether what the hip is dislocated or reduced, as we were just talking about, whether the reduction is congruent or incongruent, what is the size of the femur head fragment, whether it is reduced to position or not, and what are the associated injuries. Now, first thing is we see whether hip is dislocated, just like Professor Tanna was saying about it, whether it has to be reduced or not. Yes, it is important. If it's not reduced, it must be done immediately. Now, for that, it's better to have a good quality X-ray. This is probably somewhere around 1994 or 95. A patient came, had a very bad X-rays done. Our residents in an emergency looked at the clinical picture. The patient had a dislocation. The X-ray was not clear, but they tried reduction. Now, what subsequent X-ray showed was not only a neck, this head fracture along with a neck fracture also. This could be a complication. Now, then it was facilitated, the reduction, he got it, but it was actually a fracture which got created while attempting this reduction. So, as Professor Tanna said, you have to be very careful about this reduction procedure also. If you're not clear about the X-rays, you have to be very careful about it. It must be done very well at that stage. Then, whether this reduction has become congruent or not. If you look at the first two cases, you can see it out. It is smooth, it is congruent in the CT also. But here you see a larger space. And when you see the CT itself shows that it is not an appropriate position. So it needs to be taken care of. Then, what is the size of this fragment, which you see over here? Here we see a case with bilateral injury. You see a small fragment, you see a bigger fragment. So this is a big fragment. It obviously needs to be put back. It is a small fragment which may or may not be put back if it is not causing any incongruity. So it's very important that any big fragment must be reduced appropriately. Next comes, how is the associated acetabulum fracture wherever it is there? It could be a simple small fragment of the wall. When you reduce the hip joint, it reduces and the wall fragment does not create that level of instability. And it's an outcome which is okay. While in this kind of a situation, the fragment is bigger and you need to support, as Dr. Pradeep just showed this presentation, we have to support that acetabular wall also. Now, Pipkin was a standard classification, but in the experience we have found it out that for decision making, this Brumbeck classification is much, much better in this kind of a situation. Here, the Pipkin 1 is divided depending upon the associated acetabulum fracture into 1A and 1B. Depending upon, again, Pipkin 2, it is 2A, but whenever it is associated with the acetabulum, with the posterior dislocation, it is 2B. 3A is a pure neck fracture with dislocation, and 3B is when posterior dislocation, neck fracture, and femur head fracture. And then 4 is the indentation fractures, which were never talked about in the Pipkin classification. 4B is the sleeve fractures, which were again not talked about in the Pipkin classification. And 5 are the medial injury or these quadrilateral plate injuries or the anterior column injuries, which again have not been talked about in the Pipkin classification. So Brumbeck classification gives much better management plan. Now, if we have to make a management plan, we have to take some decisions again. Whether we accept this close reduction or not. Yes, as we have done over here, this was the one, we reduced it, the fragment settled very well. And you can see 6 years follow-up of that patient doing reasonably well, in spite of that very small fragment, which actually is the attachment of the ligament over there. Now, if the fragment is causing an issue, then we have to do the reduction. And it has to be operative reduction. But as I told earlier, if the fragment here is small, and the down there, this fragment is small, here it's not even visible, then you don't have to. So the size of the fragment and its congruency does matter at this place. There was an interesting paper published by Chen in 2011, which had got an interesting thing. They said that if you, in these very small fragments also, if you do reduction and excision, operatively, the chances of AVN are less. While our observation has not been accordingly. So once they published this paper that excision, it must be operative reduction or operative excision, we gave them the counter reply. One of my 2 students, both of them wrote to the International Orthopaedics editor that this is not a right statement which they have made. And we set it out, which they eventually agreed to, that this is not the concept which should be built, that the surgery is essential to reduce the chance of AVN. It has nothing to do with the AVN. We already were talking about this very thing. It is the reduction timely which is more important, whether it is operative or conservative. The conservative management does not increase the chances of AVN. Now, next is close reduction is acceptable or not. Now, here there is a big fragment we can see. We did close reduction. We got a CT scan. It came back to its own position. Now there could be an issue whether we should operate upon this kind of a well-reduced fracture or not. Technically, we observe these cases. And if they stay in that very position for a longer time as it stayed in this case, we do not have to operate if it is a stable kind of a situation. But if that reduction is not appropriate, obviously we have to operate upon. Now, question comes, what is the surgical approach we go? We were initially doing with the kind of a posterior dislocation. So we were going with the KL approach. We were fixing it up in this way. These are our initial cases. And when the hip was reduced and the fragment was primarily anterior, as you can see over here, we were accessing it with the Smith-Peterson approach by a T type of incision into the anterior capsule, opening it out, and many times you have a totally rotated fragment 180 degree. So derotating by distracting the hip and then getting it back to that position. So this has been our practice in all cases where the hip is reduced and where the approach can definitely be made from the anterior side. And in that we may be able to use this kind of a K. This is you can see the fracture over here with Smith-Peterson. We put K wires to hold the fragments to manipulate them, as you can see over in this image. And once we have manipulated, thereafter we stabilize them. And this is the stability we have, get it from the Smith-Peterson, which is not very morbid kind of an approach. We are just restricting yourself to the area. And as we know, this fragment is primarily anterior-inferior. And this way our access is quite good. Here, there is a case which is the same case, probably, or maybe a little different case, but the same character, where you can see the fragment is rotated 180 degree. We went there, we reduced it there, put it back, and now you can see this is his 7th year follow-up, 10th year follow-up, 12th year follow-up. There is another case of the same kind, similar kind of a situation where the fragment is rotated 180 degree. During that reduction procedure, we fix it. This is his 6 years follow-up, and this is his 16 years follow-up. Now at this stage, they do start developing radiological signs, but they do have, and he does have little limitation in getting full this thing, but he's comfortable for rest of the movements. There is another case. Now, this is a case which made us to think again, because I tried with the same reduction also, and reduction of the dislocation also from the anterior side, and it was a difficult situation. But at that time, our experience, I mean, you can see the year, it was 1999. We were not very knowing about Gaines approach or flip osteotomy. So I just tried my best and I could get a reduction, but it was definitely a difficult reduction, where I subsequently went from the anterior side to fix this fragment. And this is his 3rd year, 7th year, and the 14-year experience. He has developed reasonable amount of changes. We can see the kind of a restriction on this side which he has got, but again, he is not symptomatic for that purpose. And as I told you, at that stage, we were realizing that we need to do, and by that time, we were made aware of the other approaches with the trochanteric flip osteotomy, and that is what we tried doing along with the KL or Gibson, the Gaines approach, by taking this thing and getting the femur head out and then doing the reduction. And this is the way we do it. We get it back, hold this thing, get this reduction, fix it up, and then we reduce it back and close the osteotomy. So this Gaines, so-called safe surgical dislocation, became the standard approach subsequently in patients. Again, I'm re-emphasizing this point, where the hip is still dislocated. If the hip has already been reduced and there is only a fragment which is anterior-inferior, I'll still prefer to do a Smith-Peterson approach, because it is much less morbid approach than that. And when we are going from posterior side, now we don't go for the classical cochlear leg and back, we go for a Gibson approach for all femur head fractures, where we don't cut these posterior structure, we go above that and then do a flip osteotomy to go anteriorly along this thing. Here you see the same kind of a thing, the hip was dislocated, the fragment inside. So we went from the Gibson approach, stabilize the flip and stabilize the femur head over here. And this is her 2-year follow-up. We do, as a routine, always get MRI scans after 3 months of any dislocation, because we have published our series also that when to do a MRI to know about the AVN is right time is 3 months. Before 3 months, there are lot many images which can be seen on MRI, the artifacts are there. And after 3 months, we can still see it out, but then it may be late. So the best time to look for AVN in any dislocated case will be around 3 months. So this is her 2 years follow-up, and this is her 7-year follow-up, which the hip is doing reasonably well. Another patient with the same kind of a situation, we went with the Gaines, we went with the stability of the femur head through the Gaines approach, and this is his 3-year follow-up. As a protocol, we always, as I said, do the MRI at 3 months, where we tend to find it out whether the patient is going for AVN and not going for AVN, and if they are not going, this is his subsequent 7 years follow-up, you can see over here. Now the question comes, what kind of an implant? Initially, we did not have those good implants, so we were using these simple small screws, small fragment titanium screws at that stage, so that we have to get this MRI subsequently. And we used to cut out into this area like this and put the head inside under the cartilage. It could be look on the X-rays over the bone, but it used to get embedded. And we must understand that this is on anterior-inferior side, which does not come into the weight-bearing perspective. So it is never a problem if it is even outside also, but still we were pushing it inside in this kind of a situation. Then we got Herbert screws. Then we were using those Herbert screw for the fixation. And in between, one of the commercial companies brought this biodegradable screw. This is what we had done with the biodegradable screws. The problem with these biodegradable screws was, as we wrote to this company also, that if these screws are in an articular area, they used to generate a lot of reaction fluid into this area. And one of the cases where we used this screw, the reactive fluids was so much that we had to debride it out. And the patient was symptomatic enough, and eventually one of them got infected also. And that is so thereafter the company also withdrew these implants. So now we are not having these implants available with us. Now, another type of a fracture comes a kind of a indentation injury. Now here we have got a fracture neck femur on one side and a fracture of the femur head. You can see the flattening of this area. Now this is much better seen over here, the flattening, a kind of a indentation, which we classify as a 4A injury. This again, it is seen over here. Now the question comes, what to do in this kind of a situation? Now, in this kind of a situation, at that stage when he came, we were not doing much. So we started observing it. You can see the kind of a situation. This is his 6 years. We have still the same kind of a situation. Patient does not have any of the problem. And this is subsequently his 8 years follow-up. Again, the indentation stays, but you can see his functional ability. He's as perfect, and you can look at his range of movements also. He's reasonably, the other side screws are also out. So this is not a very big indications to get into in cases, though the recent literature says a lot about taking this up, putting up these grafts and fixing. So if we are able to have that level of care available, we may be able to do it. Maybe if I have got a case, I have got a similar case to present subsequently. If there is a time, I might present that kind of a reconstruction subsequently. Anyway, now if the fragment of acetabulum, we have to see how big it is along with the femur head. If it is a big fragment for the acetabulum also, we have to fix acetabulum also. Here we fixed femur head also. You can see the small screw for that, and the acetabulum also. This is subsequently 7 years follow. Now this is a case who was 62 years. He was a Granthi in a Gurdwara. He had this injury. We told him at this age, we won't like to reconstruct because it is already 4 months old. So we told him we will try to do a replacement after reconstruction, which he did not agree. He says, this is very bad for me. I can't do it. But he agreed after about 6 months of handicap. Then he came and then we did the reconstruction in his case. But another case, same way, 3 months old neglected fracture. He came late after 3 months. So we gave him that as a choice, but he says, no. I don't feel that kind of a disability. So he just negotiated that I'll keep on coming to you to show. And this is 4 years later. You can see that pseudoacetabulum which has formed has been able to give him a reasonable amount of a support where he was able to sit. And then he came at 6 years also. You can see a kind of a pseudoacetabulum and the kind of a stability which he has on either side of it and his ability. So many a time in those cases where you have got a reasonable stability maintained, in our class of patients who have to sit down may have this kind of an outcome also. Now, a fracture where there is a neck fracture and the head fracture is the worst kind of a situation, and international literature clearly says that you have to make a decision whatever the age is towards the replacement. However, in a very young patient, you can try. You can look at the date. This is 2nd of January 2005. Now, at this stage, what I tried was to reconstruct, and you see this femur head was on the table with me. I reconstructed it, put it back. 6 months later, this is the MRIs after 6 months. Till 6 months, it looked to be quite okay. You can see over here the vascularity and everything, but he went to New Zealand to study. He came from the New Zealand after 6 years for his marriage. And at that stage, there was a avascularity. There was again this thing. And he never considered it a disability, his inability to sit cross-legged, because you don't, in a routine level, you are not looking at that kind of a position. So he was quite happy with his outcome. And you can see that in spite of that AVN and collapse, his head has adjusted according to the situation. But if such a case, which is a neck fracture along with the posterior dislocation, which we again classify as 3A injury, if it's a 60 years male, so you don't like to do any reconstruction, you just replace it. And if the same is associated with an acetabulum fracture, again, it is quite easy to get back, reconstruct the acetabulum and do a replacement in this kind of a situation when it is late. When the trochanteric fracture is associated, we can obviously reduction of the trochanter and then reconstruction of the femur head can be done. Again, these are very old cases which we have got. The question comes if it is again, as Dr. Tanna was saying about old injuries. This is a 4-month-old injury in a 22 years. Now, you don't really want to do a replacement at this stage, as we were just discussing. So in this case, I just excised out the rest of the things and put this femur head back to its position. And once I put it back, the hip was stable. I knew that this is likely to go for AVN. So I did a lot of drilling into the area so that I could get vascularity. And this is him after 12 years. Now you say he can sit, he can stand, and you see both the sides, he's able to stand over there. Yes, it is degenerative, but it is 12 years after that dislocation where there was a delay of months. another situation. It is a delay, 21 years and 4 months injury. The problem here is here you don't see the other fragment that has actually dissolved inside. It was absorbed totally. So when I opened it up, it was very difficult to do. So what I took was, I took a allograft head according to the diameter of this area which we measured and put it over there. And this is the reconstructed kind of a situation. And this is MRI as a 4 months after the surgical reconstruction, which showed that probably there is some kind of vascularity, and this is after 2nd year, and this is after 4th year. You do see there is a kind of a protrusio over these, but and definitely her movements are a little restricted. But once she's walking around, so we feel reasonably okay. Even now, about further 10 years now, we have been able to communicate with her on telephone. She's okay, and rather she's so comfortable that she has not told her in-laws also after the marriage about her any issue with this with her inability. So verbally we have got that kind of a backup. Anyway, this is another situation which are not even classified by Brumback also, meaning by the fracture of the femur head where the lower part is intact but the upper part is gone. So here we reconstructed that femur head. The base was, so we could reconstruct, but you can see after that reconstruction, this head was, this part was getting avascular. This fragment, he was symptomatic. We thought this could be the reason. So we took, we dislocated and took this fragment out, but he had a difficulty. You can look at the veins at his face. And so we had to go in the 4th year, we went for that replacement. That was somewhere in 2009 or 2008 when we replaced it. This is his follow-up. Now another case which I have shown number of times, a kind of a learning case for me and probably for a lot of people around, which, because this is the case which I have presented in many international fora, and the outcome has been very different in the sense. You see the same kind of a situation where I fixed up the upper part of the femur head over there with multiple screws, but you see this is going for avascularity. Now the question is, if it's going for avascularity in a 22-year, 23 by the time she becomes, and the things are bad, and you see how they are going from bad to worse. She's trying her best to get the range of movement, hip is stiff. You can see the kind of a restriction. She barely is able to put a weight on the affected side, otherwise she's using stick even at 1 year. Now we were very disheartened when we have had this picture at 1 year follow-up. You look at her in this kind of a situation, she was attempting to fit, she was attempting to put a weight with this hip, with this support on this side, and you don't look a wince at her face, meaning by she was painless. And this is what prompted us not to intervene, because she was pain-free, and when she was pain-free, whatever the restriction was there, we allowed her to go. And this is her at 3 years. When she came to show after 3 years, she had got a similar, as I showed in one of the case, a collapse, but reformation of that very head at that level. You see the lateral view also shows a reasonably well made out femur head. And look at her ability to sit and squat, she was okay. Then she, a few years back, we contacted her again on phone because she's at the other station. So she sent her x-rays on this thing, WhatsApp. This was her first x-ray, and 7-year follow-up, these were the x-rays. You can see her ability to sit now, her ability to bear weight now. And just last year, again I asked her, because she maintains that communication, again I asked her to send her 10th year follow-up, and this is her 10th year follow-up. Again, you see how beautifully the head has reformed over that area. Here you can see the lateral, and here you can see the ability for her to stand on either side and to sit back. And then I asked, how are you walking? And this is what her walking was. She sent this video. So that was the kind of a outcome which really surprised us also. But very important in all this discussion is to know what can go wrong. This is a case which came to me for an opinion that this is the surgery they had done and this is the problem which they have now got it. So if we are doing a GANS approach, we should not enter into this kind of a complication. That's very, very important to define it out. Then this is our own patient who got this problem of AVN in the 3rd year. This is again way back when I was not doing that kind of a pre-operative, post-operative MRI work. So we got it after 3rd year when he came to us. Again, I went in, put a lot of graft, and this is 9 years subsequently. And this is one of the first cases. I mean, it was in 1997 when I had this case, which has got a fracture of the femur head along with transverse fracture. And this is a very important dear case to me because this was the case when I actually so-called innovated the iliofemoral approach. I found it out that I was looking at Smith-Peterson approach, and very easily while doing Smith-Peterson approach, I could go proximally by doing the osteotomy to reach back. And this is the kind of the stability which I could do to the acetabulum also, along with doing a screw into this area. She, after 10 years, landed up with the arthritis, and then she got a replacement done at this year. And now this is 18 years. She's still with me with the follow-up. Now she's 18 years back after my first surgery, which I had done her in 97. Now, if you look at the outcomes, if you look at this is a series of multicentric study with a kind of a collection of 147 cases. And if you look at there, the problem with this kind of a follow-up is their follow-up is 6 months even. So 6 months is actually, as we know, is not the time when we can have all the complications lined up. So they had the problem of early fixation failure. They had the problem of avascularity at 9 months. And so this is heterotopic ossification was very high in them. That was not so high in our cases as such. The last follow-up, which we had done about 3 years back, at that stage, I had 30 patients where I had a follow-up of more than 5 years. And what is there? 50% were normal. And definitely, I have to be very clear about it. These are all those cases of Pipkin 1 and Pipkin 2, so-called, where we could achieve a reasonable amount of a reduction, where even everything was normal, the X-rays as well as the clinical profile. Then there were 10% of the cases where radiologically they had degeneration, clinically they had no issue. Then radiologically AVN, another 20% cases, clinically they had no issue. We had done early THR in 6%, late THR in another 7%, and compromised. We wanted them to get a THR, but they were not willing to get a THR or another 7%. So overall, when we look, as most of the cases do have a reasonable amount of a satisfactory outcome in these injuries. A question of AVN, as Dr. Tanna was asking about it, a very interesting thing which we observed in our series was that in India, that's what we emphasize, in India, I have used now all the approaches, but the chances of AVN have been same even in GANS also, even in Smith-Peterson also, even in posterior approach also, and even in close reduction also. That's a very interesting thing which I am saying, because in India, the patients, maybe my series is relatively old, the patients were not coming to us within 6 hours or 12 hours. I was in a tertiary center, so we were coming, they were getting after 2 days, 4 days, 7 days, 10 days. And when they are 10 days old, then whether you do a GANS reduction, GANS approach, you do a Smith-Peterson, or you do a posterior, probably at that stage, it does not matter. That is what we perceived out of our experience when looking for AVN. Now, as far as going Smith-Peterson or going for GANS, this meta-analysis says that they have not really found much of the difference. It is the ease of surgery which is most important. Otherwise, as far as AVN is concerned, this approach will not matter. But definitely we know that if it is a pure, if it is a dislocation still to be reduced, GANS surgical approach is the best. But if it has been reduced, we can go with the Smith-Peterson approach to get it. So this is whatever this thing. I had an initial publication, JBJS, way back in 2009, and now just I got the other publication in the later, one of the latest. This thing is where we have concluded these very things, that Pipkin 1A can be managed by close reduction, but if it's likely to be incongruent, we should get into surgery for removal or excision, whatever the size suggests. For Pipkin 2 or Brumback 1B and 2, it is definitely require surgery, and if it is a reduced head, then we should go for a SP approach. If it is not reduced, we must go with the gas approach. Brumback 3, usually THR, but may attempt a kind of a open reduction with an expectation of getting something good, maybe at early stage, maybe at late stage. We may be avoid arthroplasty. In Brumback 4, indentation, yes, it is an acceptable level of a thing. And maybe if we have got the facilities to reconstruct, to put up reconstruction, we may be able to do that part. And Brumback 5, where there is a medial, the quadrilateral plate or anterior column, definitely they will need surgery for the acetabular side also, so they need that kind of a situation. Thank you.
Thank you, Dr. Sen. It was an excellent presentation with a very long follow-up, and you're going to clear message when we should do, when we should select which approach. And you are in favor of preserving the head more than replacing the head.
Yes.
Thank you. I request the faculties if they got any questions to Dr. Sen.
Ramesh Sen sir,
Sir.
do you have any idea regarding the radiological picture? There is a mushroom-like picture, and is there any correlation between the size of the head post-surgery and the functional outcome?
Yes, the question is, there is a very important thing when to get into. I think Dr. Tanna might remember we had this discussion that he asked me, you are too conservative, you are making your patient to suffer for a long time before getting a replacement done. Sir, you remember it? So you told me this thing. But I understand till patient does not ask for any this thing, and for pain is a very important factor. If the patient is painful, he will definitely get the surgery. He cannot tolerate pain. But stiffness, fusion, we know many of our patients with the stiff hips can do manage many years also. So whatever the situation of the hip is, if the stiffness is the problem and if he feels it, we can go for a reconstruction. But I always ask the patient for his choice, not looking at the X-rays for that level, if he's helpful. Now, as far the size is concerned, we all know that after the avian, there will be a collapse. Now I'm doing a lot of work on the avian itself also. I have got about 700 cases of avian with me, which I am following for a reasonable period of time. What we have seen it, something which needs to be looked up in the literature also, which I was looking for it, that when we have got the avascularity, there is a stage when there comes a collapse after the initial depression of that segment, which is avascular. And let's be clear, after that collapse, the patient becomes pain-free for a variable period of time. Now, this period, if the hip does not cause FAI, an impingement kind of a issue, he is not painful for 4 years, 5 years, 6 years also. Only when the restriction starts in stage, he becomes kind of a disabled, and that is probably the stage when we go for arthroplasty. So in these patients, now the patients which I have shown you, where we got a good kind of a outcome, even with the established, the head has become smaller. But what has happened? It has not led to a FAI kind of a symptom. Stiffness was there, which gradually resolved, and the same head kept on working around, even with the smaller thing. And this is something like Perthes disease also, where the patient does not have a pain, but has avascularity, which eventually allows the head to reshape itself into the given situation. So I personally feel it that our perception of Perthes matching into this kind of avian is appropriate kind of a conclusion.
Okay. That means you are of the opinion that the patient has to demand surgery. You don't
Yes, that's always. Yes.
You don't steal the surgery. Patient has to buy the surgery.
Though I do a lot of hip replacements. Every week, before the COVID, I used to do about 5 or 6 hips and about maybe 15 knees joints. But that does not mean I stretch my indications to do the surgery. And Dr. Tanna has always commented on this. I remember his words that you are too mean for surgeries for these patients.
Thank you, Dr. Ramesh.
Particularly Ramesh.
Yes, sir. Yes, sir.
Particularly Ramesh, when the results of a good THR, patient is normal, while we continue the patient to remaining painful in a people who are in about 40s or 50s, where their activity level may be reduced, where the recreation level will be reduced. Okay, whether it is worth offering them a total hip which will last for 30 years. It is what is you and me have discussed again and again.
Sir, it is pain. I told you they are pain-free. Once they are painful, they definitely need surgery. No issue about that. It is the question of a restriction of the range of movement, which we know and given an option to the patient. If he is not painful, he may not opt for surgery. And that is my consideration. If he is painful, obviously he is asking for it. Yes. Dr. Lokhande wanted to ask something.
I totally agree with this. No, thank you, Dr. Ramesh Sen. Now we move on to the next talk by Dr. Mahesh Kulkarni.
Wait, can I ask?
Yes, sir.
Can I ask one question?
Yes,
to
sir.
all of you. When the hip is posteriorly dislocated, along with the Pipkin's fracture, which is lying posteriorly, why do you have to go anteriorly when already the posterior capsules and everything is ruptured? Why can't you go posteriorly and fix it up?
Atul wants to answer.
So if it is reduced, then I will go anteriorly. If it is not reduced, I will go by Gans approach or a posterior approach. Because if you open it from posterior approach and the hip is dislocated, you don't see anything. Unless you do a flip and a Gans, then you will see. And if it is closed and most of the times the fragment is anterior, which is very easy to locate.
Vijay, you want to ask one question?
I think you didn't get my question, Atul.
Yes, sir.
If the hip is posteriorly dislocated, all the posterior capsules and posterior structures have been ruptured.
Yes.
If the fragment is posterior, still people talk about going through the Gans in order to avoid the damage to the vascularity. Is it justified?
So,
that's what I'm asking.
Sir, here I can answer. The fragment is almost never posterior. It is always antero-inferior.
Inside.
And that's typically because one's head is slipping out, it is the anterior part which is sheared off. It is only in Pipkin 3 when it is posterior because it is fragmentary, and that we go posteriorly also. In that case,
yes,
we may not go for the anterior side. But as a 99% rule in a type 2 or the Pipkin 2 or Pipkin 1, it is always a antero-inferior.
It is anterior.
Which, as Atul said, you cannot access from posterior side.
We are talking about wherever the CT scan and everything shows that the fragment is posterior. Now,
then posterior.
Then you can go posterior, you know.
Then posterior, sir.
Yeah, that's what I'm asking.
Yes. Okay, sir. Thank you. Thank you, Dr. Sen. Now move on to the next talk by Dr. Mahesh Kulkarni.
Hello, sir. Just sharing my screen, just 1 second.
Yeah.
I thank you, MOA, for involving in this webinar, the president as well as the rest of the organizing team. The talk that I have been asked to give is about central fracture dislocation of acetabulum, which in fact is a misnomer. And I will just take you through the next few minutes about what actually it means. So it's common to get a reference, not only from a radiologist, but from an orthopedic colleague as well, saying that there is a central fracture of dislocation of the hip joint, which I want to refer to you. And when he says to me that it's a central fracture dislocation, it actually doesn't mean anything to me unless I see the X-rays and CT scan. Because in my book, central fracture dislocation is an entity, which is just that something you see on a X-ray, but actually doesn't mean anything from the treatment or prognosis point of view. So if we go through a few cases, here is an example that sometimes is referred to as central dislocation of the hip joint, but we will quickly go through some of the easy things to do to reach a classification before you refer these patients on. So these are all classified as central fracture dislocations of the hip joint. And we will go through this case to define what exactly does it mean. So this is a fracture, comminuted fracture of the acetabulum. Here exactly the hip is not gone centrally, but it will allow me to show you some of the lines which will take me through to a classification before I refer these patients. So these are the 6 lines which everybody knows: the dome, anterior, posterior wall, the ilioischial, iliopectineal line, and the teardrop are the 6 lines which will give me a diagnosis on an AP X-ray. So if the ilioischial line is broken, so if the posterior column fracture line is present, then you can safely say if it is disrupted, then you rule out a simple posterior wall fracture, and you also rule out an anterior wall and anterior column fracture. So it is pretty straightforward. Now, on top of that, if iliopectineal line is also broken, if the iliopectineal line is also broken, that means an isolated posterior column or a posterior column, posterior wall fracture has been taken out of the equation. If there is a fracture of the inferior pubic ramus, as you can see here, if the fracture of the inferior pubic ramus is present, then you rule out a transverse variety of fracture and an anterior column posterior hemitransverse fracture, because a transverse fracture or an anterior column posterior hemitransverse will not exit into the inferior pubic ramus fracture. Then you are only left with two fracture varieties, is either a T-shaped fracture or a both column fracture, which is being left behind. So if the articular surface is completely free from the axial skeleton, then it becomes a both column fracture. Otherwise, it remains a T-shaped fracture if the articular segment is connected to the main skeleton. So in this fracture, it looks like it's going to be a T fracture, as you can see on the CT scans here. Another example here, you see that this is referred to me as a central fracture dislocation. But if you see the ilioischial line is broken, the iliopectineal line is broken, and you can also see that there is a little piece of posterior wall which is floating around. So this is actually not a central fracture dislocation, but it's a transverse with posterior wall fracture with displacement of the fracture medially with the force of the hip joint. And if you get a CT scan, you can see a supratectal fracture of the transverse fracture of the acetabulum with a comminuted posterior wall. And in these cases, again, as we've been discussing, because the fracture is supratectal and quite high in the sciatic notch, I find it is useful to do a Gans trochanteric flip so that the tension on the abductors is reduced. You can access the superior part of the acetabulum, and also there is less stretch on the superior gluteal neurovascular bundle. And you can fix the T-shaped, the anterior column part with the posterior to anterior lag screw and get the posterior wall fragment back into place with either a spring plate or multiple lag screws, as has been done here. And the trochanteric flip is then fixed with standard partially threaded cancellous screws. And this is the follow-up for that patient. Another example of a patient referred to me with a central fracture dislocation. Here again, you can see iliopectineal and iliopectineal line is broken here as well. Ilioischial line is broken, and there is a massive piece of wall fragment which is lying posteriorly. The hip is dislocated. He had a shaft femur, so they sorted out the shaft femur, left the hip as it is, and referred to me at 3 weeks' time following this injury with the hip out in this fashion. You can see the CT scan. There is indentation of the femoral head. The big chunk of posterior wall lies within the acetabulum, making it unable to reduce the fracture closed. So we decided to go back again by a posterior approach. We got the reduction of the posterior column and had to use posterior wall plus some bone graft to reconstruct the acetabulum. And by that time, the anterior fracture was completely sticky and undisplaced, so we did not really fix it by any means. So this is the fixation: small plate for the column, lag screws for the posterior wall and the bone graft, and the posterior column plate. This is the immediate post-op CT scan showing the reduction and also the reduction of the dome of the acetabulum. Unfortunately, this patient did not do well. I don't have the X-rays, but within a year, the hip sort of started getting arthritics and subluxed. He didn't come back for follow-up for any future intervention. Another example of a central fracture dislocation is, again, if you go through the classification, ilioischial, iliopectineal line broken, fracture extending into the iliac wing itself. And as you get more information, you can see that there is no segment of the acetabulum which is connected to the axial skeleton, making this as an associated both column fracture. Here we decided to go with a dual approach with ilioinguinal and Coquelangenbach simultaneously, and got a good reduction with a decent follow-up now of nearly 12 years for this patient. Another example, again referred to as a central fracture dislocation, with patient was put on traction, extremely comminuted fragments, a classic ABC fracture. Again, we fix it with a dual approach, with a decent follow-up now with a congruent hip joint. So these are some of the examples of what the cases have been referred to me as central fracture dislocations. This patient came to us at 4 months with complete destruction of the head of the femur. You can see that the anterior wall fragment is being lifted up with a lot of fibrosis. Here, because of the damage to the femoral head, we decided to do one-stage total hip and fixation of the acetabulum. So we reconstructed the anterior wall column fracture with an ilioinguinal approach, plated it, and then flipped the patient to do a posterior approach to do a standard total hip replacement. And we've done some acute total hip replacement in severely comminuted osteoporotic patients with damage to the femoral head or indentation, which were referred again as central fracture dislocation with fracture of the quadrilateral plate as well. Here, if you get the columns back with an ilioinguinal approach, here we've used a spring plate as well for the quadrilateral plate, bone graft, and then use a cup which is an advanced ingrowth surface, which allows you to get multiple screws in place and gets the patient out of the bed much faster than trying to attempt to fix this in very elderly osteoporotic patients. So basic thing is to make sure that you do no harm by putting in a lateral traction in greater trochanteric region, because if you put a pin or a traction pin in the GT region and it gets infected, it can lead to pin track sepsis and can compromise future surgery if these patients come back for a total hip replacement. So make sure that you just apply longitudinal traction and don't get involved or violate the area where you may have to go back in. So calling a hip fracture a central fracture dislocation is calling a ligamentous injury in the knee as internal derangement of knee. It doesn't really mean anything. It is like calling the pain because of chondromalacia or quadriceps tendonitis as anterior knee pain. It doesn't mean anything to me, and it doesn't allow me to take a decision on treatment of these. So it doesn't give me enough information. So I can confidently tell you that it's a misnomer. Majority of the acetabular fractures can be labeled as central fracture, but I think if you can follow the simple landmarks on a proper AP X-ray, you can make a diagnosis, tell the patient about prognosis, but make sure that you don't use any lateral traction saying that it's a central fracture dislocation. Thank you.
Thank you, Mahesh, for clearly making people understand the terminology of central dislocation is not there. It's a misnomer. The head of the femur will not go inside without causing a fracture of the acetabulum, any part of the fracture. So that is a misnomer. So now the questions from faculties. Thank you, Dr.
Can I
Mahesh.
ask you about the rehabilitation after acute replacement in an acetabulum fracture? How do you rehabilitate? What's the weight bearing protocol?
I would get them up toe touch weight bearing within a couple of days as soon as the patient is comfortable and the wounds have settled. So they will at least get up toe touch weight bearing. In a severely comminuted fracture with femoral head indentation, I think it avoids a secondary surgery in these elderly people and get them out of bed within few days, and they can start weight bearing at around 3 months post-operative.
But their surgical morbidity, as we know, is likely to increase in this kind of a situation. So
I think you can justify it by saying that if you give them 2 operations or keep them in bed without an operation, their morbidity is likely to be much higher. So these patients, I believe, which are properly selected, comminuted fractures where the reduction is going to be imperfect, these selected cases, if you are experienced enough, could be subjected for a single stage operation rather than giving them 2 operations with a gap of 3 months or 6 months.
If I can ask you, Mahesh, like a Pantuji,
Yes, sir.
What exactly you mean by a toe touch walking? I don't think anything like that exists.
Toe touch is, I think if you tell the patient partial weight bearing, he'll start fully weight bearing. If you tell them fully weight bearing, they'll start running around. So by telling them toe touch weight bearing is...
Can you ever walk with the toe?
You can walk with a walker, Zimmer walking frame. You can walk with a walker frame.
No,
You
toe
can-
touch. I'm asking toe touch.
Yes, yes. If you just touch the front part of the foot, and the physiotherapist will teach you that, we call it as eggshell walking as well. Keeping a patient non-weight bearing will make the hip forces multiply several times, because the patient has to contract the hip muscles. They have to keep the leg up in air, which will produce severe forces in the hip joint. So allowing them to partially touch the foot on the floor will stop these muscles overacting, and the joint reaction force biomechanically will be much lesser than allowing them to walk, hop, skip, and jump without getting them to touch it on the floor.
Okay, thank you, Dr. Mahesh, for coming in a very short time, in short notice. I sincerely thank you. I move upon to Dr. Atul Patil to give his talk on the floating hip.
Good evening, Dr. Kothadia, MOA, and delegates. Am I audible, Kothadia, sir?
Yes, yes, you are audible.
So today I am going to speak to you about floating hip injuries. And the floating hip injuries is defined when there is a one side, there is a pelvis and acetabulum fracture, and same time concomitant any part of femur is fractured. It is extremely uncommon injury, and it is usually is 1 in 10,000 injuries. So pelvis and acetabulum on one side, other side there is a femur fracture, maybe shaft femur, subtroch femur, intertrochanteric, neck femur, or distal femur. So that gives you a floating hip. So issues we face they are extremely uncommon. So we are not geared by doing so many cases. So each case is different. When there is an association of hip dislocation, how to reduce it, when to reduce it, it is advisable to reduce immediately, or whether we should attempt? No, we'll see how to do it. Sciatic palsy is more common. Also, the vascular injuries is another issue. A compartment syndrome or a deglowing around the hip is another problem, and mostly it is associated with polytrauma. It is whether to do damage control orthopedics, early total care, what should be our sequence. All these are issues we'll see through various cases. Timing, there are various options. You can first do, if it is unstable, DCO. You can do internal fixation of femur and pelviacetabular X-fix, or then wait, stabilize it, and all to do together. When will you operate? What is the sequence? As for Suzuki, he mentioned the patients with pelvic rig fracture, external fixation should be performed first. In patients with acetabular fractures, femoral fractures should be treated first. So when you are combining acetabulum with femur, so do femur first. When you are combining pelvis with femur, then do pelvis first, and then you go for the femur. A case of transverse with posterior wall, polytrauma, femur fracture, upper end tibia fracture, renal failure, hip fracture, head injury, abdominal injury. And so what we did, immediately we have given a skeletal traction and we went for stabilization of the patient. So these were his CT scan saying that transverse with posterior wall element. And this is the intraoperative. This was done. So lateral position, I always do a femur fixations in lateral. Do lateral fixation of femur, extend the same incision and do a Cocker-Langenbeck approach, fix the posterior element, and the transverse component of the anterior column is fixed by a long anterior column screw. This was how it was intraoperative. So this is immediate post-operative X-ray, both Jude and the AP view. Another case of polytrauma. Here there was a acetabulum fracture. There was a hip dislocation. There was an undisplaced neck femur fracture and the shaft femur fracture and the radius ulna fracture and the chest injury. So again, the patient was stabilized and taken for early total care. This was the CT scan which was done. and the patient was put into skeletal traction. The lateral position was given. The first I have put the Steinman pin in the head and the neck. Additional KYs were put to stabilize the intracapsular neck femur fracture. Then with the key handle, tried to reduce the hip, which I could reduce in first attempt. And then once the hip is reduced, then it is easy to take an entry point for the femur. Then completed the femur in the lateral position and then extended the same incision above for acetabular fracture fixation and fixed the acetabulum. Then made the patient supine and treat the radius ulna. So this was the immediate post-operative X-rays of the same patient. You can see the tan nail and the posterior fixation of the acetabulum. This was the AP and Jude views of the same patient, immediate post-op. And this was where you can see the gumming completely united the pelvic ring and the united fracture shaft femur as well. Another case, posterior column fracture with bilateral femur and tibia fracture. Here again, as Mahesh said, this was as per the radiologist, this is a central fracture dislocation, but this was following the posterior column. So this is a posterior column with the displacement inside. Also, there was a bilateral femur fracture and the tibia fracture. Again, the patient was stabilized, and once the ABJ is normal, once the lactate normal, then surgery was planned after stability of the patient. Again, interlock first, and then lateral position was done for the femur interlock, followed by KL approach for the posterior column, and then shifted to the lateral for the interlocking nail for the opposite femur. This was the CT scan, and you can see the displacement of the acetabulum. This was the immediate post-op X-ray. You can see the femur interlocking done, and the posterior column is fixed with the two plates. This was Jude views, and you can see gumming up fracture, healed acetabulum fracture, healed femur fracture, and healed tibia fracture. Again, a special case came to me. A 9-year-old boy had a run-over injury by truck, and he had this very bad ABC, bicolumn fracture with the shaft femur fracture. So this patient was, when he landed, he was in hypotension. So we have put him in the Thomas splint and a skeletal traction and stabilized the patient, giving a blood transfusion. And once the patient is stabilized, we have taken him for the surgery. This was his CT scan. In first time, we did supine position, we did the tense nails, followed which the patient was shifted to the lateral position, and from the lateral position only tried to fix everything from the behind. We got not absolute hairline reduction, but we got a stable reduction, and we aim for the secondary congruence. This was complete union after 1.5 years. You can see the femur, the acetabulum fracture is very nicely healed. There is a secondary congruence. The head is slightly ballooned up, but it's okay. The patient is doing all activity. Patient came back for implant removal at the end of 1.5 years for the femur tense. And he could do all the activities together. And then he was, in the end, he was happy person. This was his function at the end of 1.5 years. Another patient who came to me with a very bad floating hip. This was a neck femur fracture, intertrochanteric element fracture, thus inward pelvic migration of the femoral head, and a bicolumn fracture. It was not bicolumn, it was a T type of fracture. So it was confirmed with the CT scan that was a T fracture with the inside migration, the neck femur fracture, and the intertrochanteric fracture. Again, the patient was stabilized and then decided to do surgery in the lateral position. So I do most of my IT and shaft femurs in the lateral position. So that gives me advantage of doing Cocker-Lang airbag in same sitting, same sequence, initially open reduced. This was a complete open reduction of the neck as well as the trochanter. Temporarily stabilized the head and neck with the Schanz pin, then got the head completely out of the pelvis, then fixed with the dynamic hip screw and the derotation screw and a cerclage wiring. Same incision was extended, for a Cocker-Langen back, did the posterior element fixation of the T fracture, and this patient was 125 kg with the pot belly. It was a tough time to do anterior surgery. I did an iliofemoral approach and the buttress anterior column with the anterior column plate. This was 1 month post-op, and then patient went to have a good uniting fracture, and the patient had a congruous hip. So another patient with the polytrauma with now pelvic fracture. So this was the patient with the open grade 3B femur fracture and an open book injury to the pelvis, slight vertical shear element as well. This was the clinical picture, and patient was unstable, so decided to take the patient inside the theater, did DCO for femur and pelvis and tibia nailing, did debridement and the skin grafting all together. First, I fixed in supine position the pelvis first, closed the pelvis, then did the femur fixator, and then in the end, we did the tibial nailing as well. So this was immediate post-operative picture on table. And then this external fixator, once the wound healed, was converted to limb reconstruction system, LRS. And then the patient had good union. You can see the pelvis is very nicely closed. Patient is walking comfortably. He had a restriction of knee movement. He had around 60 degrees of knee movement and an external rotation deformity. But he was happy. Subsequently, the tibia also united. Then after 1.5 years, patient had a trivial fall at home, due to slip and fall from the wet surface, and he broke his femur. And then again, this needed open reduction, correction of angulation deformity, and the fixation with the intramedullary nail and the bone grafting. And in the end, assess it with SI joint separation. Again, the principle here is to fix the pelvis first, posterior first, then the pubic plating, and then the femur. So here the pubic symphysis first sacroiliac fixation was done, then the pubic plating was done. Then this patient was shifted to the lateral position for the femur interlock. Then anesthetist said to wait. So we staged the opposite femur, and the opposite femur was done, and the patient had a good end result. So friends, coming to the patients with multiple injuries, with floating hip injuries, it is almost associated with polytrauma. You have to first see whether the patient is stable and the borderline or unstable or very serious. If the lactate is less than 2.5, you can plan for early total care, and if the ABG is normal. If it is borderline, resuscitate and see the trend. Whether the lactate is improving, ABG is improving, then go stable, then go for early total care. But if not, then uncertain, then do damage control surgery and send him to ITU. Unstable patient will directly go for a damage control surgery when the BP is not maintaining, and then patient is shifted to ITU. Very serious patient in the casualty, you manage him, patient in ITU, and whether he survives or not survives, then depend on the further plan can be decided. So friends, floating hip, either pelvic ring fractures with the femur fracture, unstable patient, always go for a damage control orthopedics. When the patient is stable, and then you can go for a X-fix and femur fixation or definitive fixation depending on your surgical expertise. When there is acetabulum fracture, reduce hip if you can possible, but beware if there is a neck femur fracture and intertrochanteric femur fracture, it is very difficult to reduce, then reduce this intraoperatively. Femur fixation, if you are the surgeon, then you can do a femur fixation antegrade and fix the acetabulum in same position. But if you are not confident in supine position, you can do a retrograde nailing. And if somebody else is doing, this is better to do because you don't violate the posterior incision area, and then refer it to the acetabular surgeon. If it is unstable, always go for a damage control, stabilize patient, and then think of definitive fixation. So in conclusion, this is a very devastating injury. Most of the times it is associated with polytrauma. You have to decide whether for damage control or early total care. You should be ready to change the principles of a stable patient and unstable patient, and you have to listen to anesthesiologists when you are practicing this floating hip injury surgeries. And heterotopic ossification and neurovascular injuries are more common in floating hip injuries. Thank you, everyone. Thank you, sir.
Thank you, Dr. Atul. It's an excellent lecture, clearly saying that when pelvis should be fixed first, and when femur should be fixed, and when acetabulum and femur, you should fix the femur first and the acetabulum. It was a very good, excellent presentation. Thank you for that. Any questions to Dr. Atul?
She married the boy who he wanted to marry. She wanted to marry him.
Sir, we are not able to hear you properly. Anna, sir.
I just want to ask one question.
Yes.
When the fracture neck femur is there and the hip is dislocated, then you would rely on those K wires, and because I personally would find it difficult to pass the screws in a dislocated position to fix the fracture neck femur.
So I always pass. Yes, complete.
So what is the trick? Means you have you have to be gentle, and means what? How do you prevent the displacement of an undisplaced fracture neck femur?
So
That is my question.
most of the time, the neck femur fracture in this floating hip injury scenario is undisplaced.
Okay.
So if it is undisplaced, then you have to put two things. You can use threaded K wires. You can put around 2.5 or 3 mm threaded K wires. Don't rely on single K wire. You can use 2 K wires, minimum 2 K wires, if not 3. Then put everything, confirm that everything is in place, out of which one you can use a 3.5 mm shank spin and try to relocate it gently. And same time, because you are going to do so what I do, I prepare myself in the so I can puppet the head as well. So my second hand is on the head behind, with two threaded K wires and shank spin, and then gently glide it to the acetabulum.
Right.
And if it is displaced, no option. You have to do open reduction, fix it, then fix it with the screw, fix one shank spin, and then reduce it.
Right. Okay. Right.
Thank you, Dr. Atul, for excellent presentation.
Thank you, sir.
Now I request Tanna sir to say something or his views about these fractural dislocations of the hip. Tanna sir.
Hello.
You can start now.
At the outset, I thank the organizers for giving me an opportunity to share my case with you. Now, it was at 8 a.m. at 1 a.m. in the morning that I received a message from the house surgeon that the patient with a pelvic hip injury has come, and he told me that I have sent you the X-ray on WhatsApp. So at 1 a.m. when I saw this X-ray, honestly, I was perplexed, and because the hip looked bit subluxated, but the head was looking at me, and the attitude was in external rotation. So I requested him to send me the clinical photograph also, and the attitude of the right lower limb was slight flexion, abduction, and external rotation. And then the total history was he was a pillion rider. He was hit from behind by a four-wheeler. The accident took place at 6 p.m. and he reached there at 1 a.m. So the house surgeon told me that there is I had to rush because a thought of anterior dislocation came to my mind, and I had to rush to the casualty because he told me that there are no toe movements, and the limb below the hip was completely cold. So that was his clinical picture, and so the limb was dusky, the calf was bit tense, and there was obvious slight discoloration of the foot also. So we immediately got the CT angiography done, and the diagnosis was clear. There was a filling defect in the at the level of hip joint, and so we decided. Now I had to counsel the relatives that because already some edema had set in. I was worried. I couldn't guarantee them about the return of function, and I explained to them about the possibility of reperfusion injury and kidney damage, and possible complication of avian as well as post-traumatic osteoarthritis. So I involved informed the vascular surgeon, involved Dr. Pradeep Kothadia sir, who is my mentor, and I took his help. And at 2:30 a.m. we arranged for the theater. We tried the close reduction; it wasn't successful. So we went ahead with open reduction. There was buttonholing of the capsule, which was preventing the head from getting reduced. And once we cut that, we could easily reduce it. We palpated the acetabulum, confirmed that there was no intra-articular debris to prevent any concentricity of the reduction. And the moment we reduced the hip, immediately the pulsations came. Hip was completely stable. Patient was managed with a skin traction. The only thing was he had a sciatic as well as femoral nerve palsy. He had no toe movement. So most probably it must have been a ischemic or neuropraxia or a part of compartment syndrome. That is why he had a sciatic nerve palsy. So we maintained the passive range of motion, gave him foot drop splint, and he was encouraged to walk with the long knee brace so that the hip is locked in extension. So that was the surgical scar. Unfortunately, I haven't taken intraoperative photographs, but the post-op X-ray shows that it is completely reduced, well reduced, and it was quite stable. So therefore, we didn't go for a CT scan, post-op CT scan. After 5 weeks, we did the NCV, which showed that there was a neurogenic lesion of the femoral nerve with neurogenic lesion of the sciatic nerve with some activity in right tibialis anterior and soleus. After 5 months also, when we repeated the NCV, there were signs of improvement in the sciatic, but the femoral wasn't showing any improvement. But still we continued to wait, and at 7 months, you can see that his femoral also started recovering, and because of the quadriceps weakness, he had to walk with a locking his knee in extension. And just 2 days back, I had called him to know about how he is doing, and then he sent me this video, and he is able to do everything. He has no complaints. Because the COVID started, and this was in January 2019 that we came across this case. So this is his recent X-ray. So I'll just touch upon certain theoretical aspect. The classification of anterior hip dislocation. There are two types of anterior hip dislocation. Generally, out of 10 dislocations, you would get 9. That is, the 10% is the incidence of anterior dislocation. 90% is the posterior dislocation. Now, anterior dislocation, it can be either superior or it can be inferior. The force or the vector, the position of the limb would be always in an abduction and external rotation attitude. When you get a superior dislocation, then at time the hip would be in extension, and for you to get inferior dislocation or obturator type of or perineal dislocation, the hip would be in flexion. So the superior dislocation can be depending upon the position of the head, iliac or pubic, and this again can be associated with, I am not going into details about the classification, but then it can be associated with indentation fracture of the femur. It can also be associated with fracture of acetabulum. So this is just a schematic representation with the radiographs to show the obturator, iliac and pubic type of dislocation. And the reduction method would be, you need to give a longitudinal traction when the dislocation is superior, and you need to push the inner aspect of the thigh outwards to get it reduced. And then some review of literature. It's extremely rare sort of condition. Many a times there can be interposition of the capsule or rectus femoris muscle, or this is another paper from CORR, the article, which says that there was earlier a controversy whether you should operate these nerve injuries. The thing is, you must reduce it as early as possible when there is a neurological involvement. But once it is reduced, you need not explore it, because in the partial recovery is at least seen in 60 to 70% cases. And they say that magnetic resonance or MR neurography would be playing a role in telling us when to intervene or not. Now, of the superior and inferior dislocation, the obturator, that is the inferior dislocation, is more common. And vascular compromise in the form of arterial compression is reported to occur in just 1% of traumatic hip dislocation. This is a paper from JBJS 2019 December. And there are cases reported of bilateral asymmetric dislocations, meaning on one side it is anterior, on the other side it is posterior. This is from September 2020 IJO, and prompt close reduction would establish the blood flow. Thank you all for your patient hearing. Sir, sir, you are muted. I am not able to hear you.
Thank you, Dr. Milind Joshi. Excellent presentation. And it's a very rare presentation with anti-dislocation and with a vascular compromise situation, along with both the nerves involved at the same time. That is a femoral and sciatic. Now, I'd like to ask you how you expect the sciatic nerve involvement in anti-dislocation. We can expect the femoral nerve, but how we can expect the sciatic nerve to get involved?
Probable answer is ischemic neuropathy. The second possibility is it is also stretched.
So that we can see the screen.
Pardon, sir?
Stop sharing your screen so that we can.
Okay, right. So that is my, the answer is probably ischemia and a part of compartment syndrome.
So, Kothadia, sir.
Yes.
To answer this question, after seeing his EMG NCV report, which mentions the anterior tibial, posterior tibial nerve component and the deep peroneal nerve component. Yeah. So mostly it is the ischemic. So my question was that time a compartment release fasciotomy?
Yeah,
was needed or not needed?
We were ready for it, but there was no. We were thinking of it, but it was not really that tense. It was, though it was not totally supple. And let me share with you that his creatinine went on to 1.8.
So
And
in fact,
again came back.
So retrospectively thinking, if you get the same case again, will you like to do a fasciotomy?
Yes.
That time, really, we palpated the soft tissues. It was absolutely vigilant observation. But then I would really request you people to answer me, because
so when you are in doubt, I will always do a fasciotomy.
Okay, that's right. It is always better
That
to
will be, Atul, that will be a prophylactic fasciotomy mostly. It is because
So no, because on his clinical examination, he initially told the calf was tense.
but it was not really all that tense. It was definitely bit turgid,
So you should,
but it was not woody.
Atul, you mean to say? Atul, you mean to say that reperfusion will still lead to more and more compartmental after once the vascular channel opens.
Yes.
That is the thing. That's why you want to do a immediate, a prophylactic, or you can do a fasciotomy. Am I right?
Yes. Yes. What is Dr. Sen's opinion?
Absolutely. I am also towards fasciotomy, because it is always better to prevent an ischemia going further. And as Dr. Pradeep said it, because after the reconstitution of the vascularity, there has to be edema also. And it is always safer. I mean, fasciotomy itself is not a big issue. So it's always safer that we do the fasciotomy at that stage.
Fasciotomy.
Yeah. So, but I think this case was very interesting, and definitely we had some patients with this kind of an injuries. I do have a case. I don't know the literature. We have published that, which was a bilateral iliac dislocation on the two sides. So that is something which has never been reported in the literature.
With vascular insult.
No, there was no vascular insult. It was iliac. Iliac does not lead to the vascular. The pubic leads to the
iliac.
Or obturator.
So there is a difference in the, so out of the 4 anterior types, iliac, pubic, obturator, and perineal, the rarest is the iliac. Then we have pubic, and pubic is invariably, because it is exactly going to the vascular area and the nerve area, it is likely to be that effective, that positive for this thing. So iliac is the rarest thing, and because as Dr. Minden shows, the mechanism of injury is very typical of it, having an injury with the limb when it is extended, and depending upon the kind of a position of the limb, mostly it is flexed, so you get to the obturator or you get to the perineal dislocation sometimes. And once he was sitting at a 90-degree, he got to the pubic type. But if it is little extended in that position, you get it iliac type. For my case, it was a lady who was basically an American, Indian American, so-called NRI, lying on the bed when she was having the abduction, and the wall fell over, hit due to the gas cylinder blast on the other side. And she got it both the sides, and one side had a femur head fracture also. And I'm talking about 1996 or 97. So at that time, I operated with the Watson-Jones, because at that time, whatever we knew about iliac dislocation, reduction was easy, but we could fix with the Watson-Jones approach also at that stage. So I did have a follow-up for her 6 months. She also had an injury at the knee joint also with the same thing, but then she went to USA. So I lost the follow-up. But this is one of the rarest things, having a pubic dislocation or having a leg dislocation. So quite interesting.
Okay.
I have a doubt to all panelists. So if you diagnose that this is a pubic dislocation and a vascular injury, so will Smith-Peterson will be better with the modifications of STOPA? Because if you have to take control on the femoral vessel or external iliac vessel,
we can extend the as iliofemoral. Dr. Atul, can you come again, because the internet was unstable.
Yeah. So my question is, when you diagnose that this is a pubic dislocation with a vascular injury, so it is better to take Smith-Peterson approach versus a classical ilio-inguinal approach. You directly see the vessel, and you can see the inguinal ligament and reduce the pubic capsule easily.
Okay, because
my doubt. So which approach is better? And
Guys-
it is better to, because you see vessel also in ilioinguinal.
Yeah.
I think,
Right.
in my perspective,
Yeah.
getting over to the vessel from the iliofemoral also is not very difficult.
Very
You just
Not
have
very
to
difficult.
extend.
Yeah.
The good thing about iliofemoral is you are at the joint also.
Mm.
You are at the joint. With
Yes.
ilioinguinal, you are not at the joint. So with the iliofemoral, also called Smith-Peterson, at least you are with the joint also, with the dislocation also, you can clear the capsule also. In ilioinguinal, you are not into the joint. So that's the
Absolutely.
basic difference which I feel. And going with the iliofemoral, you just have to retract the iliacus laterally and get over to the vessels also, which probably I think is a better access rather than primarily going through iliac.
Making a T
Yes.
the
Any
superior part of the
extension can be
incision,
made, yes.
making
You
a
can
T.
little bit extend that and you can go to the
Yes.
joint as well as the
Yes.
basis.
And the CT angio showed that there was a feeling in distally. So we were practically sure that it was compressed and it was damaged.
Okay.
Okay. Thank you, Dr. Milind Joshi. Now we move on to the next person who is going to present case is Dr. Lokande.
Yes.
He is going to present a case. Dr. Lokande, can you share your screen?
Good evening, everyone. I would like to really thank our Honorable President of MOA, Dr. Ajit Shinde sir, and all the dignitaries and all the participants of this webinar to give a chance.
Your voice, please raise your voice.
Yeah, it is.
Louder.
Am I audible, sir?
You are audible, but the voice you have to just raise your voice.
Okay, sir. So basically, major points of this injury are already cleared by sensor. So there is not much to talk about, but I will just share my experience about this case.
Yeah.
So this was a 52-year-old male who sustained RTA with a dashboard injury, and he had a right-sided posterior dislocation of hip with associated femoral head fracture. There were no associated injuries, and he was medically fit. So basically, presented 10 days post-injury. He had an accident somewhere else from our city, and he was managed at a hospital, but actually they didn't manage it. So there are basically this case is I'm presenting it to just give an overview that many of these cases at periphery, they are not majorly managed even with a reduction of the joint, because to reduce a joint, it's not like other joints where we just pull it and it reduces. It basically needs anesthesia, it needs an operation theater to reduce a hip joint. So at many places where I go, many a times these fractures, they still remain unreduced for 3 days, 5 days, or an acetabular fracture which remains unreduced. So a simple reduction should be at least attempted anywhere. So these are the x-rays of the patient. He had a dislocated hip along with the femoral head fracture which is seen here. These are his 2D CT scans showing the fragment within the joint. Seems to be a Pipkin 2 fragment with some area of the fovea with the fragment. These are thin cuts. As the patient presented 10 days post-injury, there were some issues in regarding this injury, because at that time I was not very clear about all the evidences available that what to do in such a case. And also the age of the patient was 52 years. There was some comminution here, and the head was lying at the rim of the acetabulum for 10 days. So probably there would be some comminution with bone loss too there. So these are the classifications, the Pipkins and the Chirion classification. So it does not actually fit in type 1 because it was not just a small antero-inferior fragment and not exactly a type 2. But coming to Chirions, it may be a type 3 fragment. The Mumbai classification as told by Dr. Sen. So there were some issues in this management for me. That first it was a 10-day-old injury and unreduced hip. There was comminution and bone loss at fracture site. And whether to fix or replace, that was because it's always written in the books about 6 hours, 12 hours of the reduction of the injury. Should we really do it, or is it we should not attempt it and directly go for a replacement? But after a brief discussion with the patient and his relatives, we had explained him about the need for further surgeries in future. There were many issues regarding the replacement also, so we planned to do a fixation. These are some some of the articles available which say that yes, AVN is an important complication of this unreduced dislocation, but it is not an absolute that if a posteriorly unreduced hip that it will 100% go in AVN. There are some cases which do not go in AVN. This is again another study in which they had a case which was a 3-month-old fracture. They fracture dislocation and they managed it without an AVN. The study by Sensor, in which they say that these fractures and osteosynthesis or conservative management should be attempted rather than the other difficult ones, we should go for a replacement primarily. So my plan was to attempt a close reduction on table. It was not when the patient arrived, to go for a GAN safe surgical dislocation and ORF with the headless screws. So the patient was placed in a standard lateral position. A trochanteric flip osteotomy was done, carried out, and the head was reduced anteriorly with a safe surgical dislocation. But after I retrieved the fragment, it was a large fragment. On reduction or on seeing the fragment, there was quite bone loss there. It was not exactly congruent. So the margins which were the margins of the hip joint which were away from the rim was okay, but at the rim it had already compressed in that 10 days. Therefore, it had that bone loss there. So I tried to align it as possibly with the finger reduction done at the opposite side of the head, and I had reduced it to one position and I had fixed it with 2 K wires. And after that, still there was a persistent gap which was present there. And on table, I thought that yes, even if I fix it with the headless screws there, I could not get that very good compression because there was a bone loss there. So on table, then I decided to go for a to get a bone graft from the greater trochanter. So I assessed the area, the amount of area which was lost there, and I took a specific rectangular wedge from the GT area, and it was just slowly removed. A rectangular area was removed from the cancellous bone of the greater trochanter. You can see here. I removed that piece and I fixed it in that gap and slowly punched it so that I could fill the area. This was before the definitive fixation of the femoral head was done. The cancellous rectangular graft with small chips were packed in the defect. And then finally, I did fixation with this Herbert screws, headless screws. And at last, under a fluoroscopic vision, the greater trochanteric osteotomy was fixed with a compression by technique 3.5 screws. This was the immediate post-operative X-ray of the patient, in which the femoral head fragment and the trochanteric fixation is seen. The patient did not come very early. He came 6 months later, and I had this X-ray. This is a 6-month post-operative X-ray of this patient. So at that point, actually 6 months of time is very early period to comment on some changes which are going to happen. But it was a good sign that at least at this point, the things were okay. And the patient was moving around with a stick and he was able to do his routine activities. And then the patient went to his native place and it was difficult to get him back. But this is the only follow-up, 6-month follow-up I am having with me. But after Sensor's lecture or the discussion with him, today I see that this was the area probably I had grafted. This is the defect they're seeing. But now when I go back, I see that if we see the dislocation, it is an incomplete dislocation. It is not a completely, the attitude of the limb here, it is not a flexed, adducted and internally rotated. So the femur is still lying at the rim. It is not completely out of the rim. And it is seen in this 2D CT cut also. And we may call it as an incomplete dislocation. Therefore, it was not completely rotated. If the patient goes on to a normal function later on, we may conclude that it was probably because of this. That is, vascular structures remained intact. And we could get it intraoperatively. I drilled hole through the femoral head. Yes, I could get bleeding from that. So it was a positive sign that yes, this fixation may work. So the take-home message I think is that emergent close reduction is the most important factor predicting the prognosis. Safe surgical dislocation is definitely it's in this name that it is safe and gives wide exposure to manage all the injuries related to this treatment. Reduction of hip and femoral and fixation can be attempted even for delayed cases. That is what I think I got from this case. Thank you for your attention, sir. Thank you.
Thank you, Dr. Lokhande. I think Dr. Sen will be able to give some light on this case, as he has
Yes, sir.
already.
No, this is very, very important message which has been from this case is that two things. I mean, I'm quite happy the way the femur head is reconstructed to get its full kind of a sphericity. That's a very important point because we had this problem when the central part of it was lost or there were smaller fragments to reconstruct it. And if it is because luckily for it, because it was not exactly in the roof of it, but still, if you have got any fragment which is not articular and we have put in between, it is expected that within this sphericity, there will be a fibrocartilage formation over this area and the overall result will not be bad. Regarding the decision to get it reduced is an excellent, and that is what we feel in India, and that's our experience that whatever the delays, 2 months, 3 months, and that is what I have been able to show also, that the chances are not that it will always go for ABN, there will be chances. And again, as I was saying, I was in this operative demonstration in West Bengal. We operated 1-year-old dislocation. After 1 year, it was dislocated, but because the hip was very supple, a kind of irregular dislocation, so it was not difficult to reduce also. And it has a good outcome also. So it depends on which Dr. Lokhande rightly told that we do not have that much of even if you see those X-ray also, it is not that much rotated. So the chances of a vascularity stays over there. So I think it was a very good case and luckily very good reconstruction also, quite good.
Okay. Any other questions from any faculties?
Nicely done case.
Thank you.
Okay. Thank you. Thank you, Dr. Lokhande. We will move to Dr. Nitin for his case. Dr. Nitin Kimatkar, can you just share the screen?
Kothadia sir, Tanna sir is here. So he will probably summarize the whole thing after one case.
Yeah. There is one more case which is there.
Yes. And then Tanna sir will take over.
Yeah. He will give his views.
Am I audible now?
Yes.
Good evening, sir. I will not take much longer time. This is a 25-year-old male, had a fall from a bike. He presented with a pain and deformity in right hip, open fracture of right patella. There was bony PCL avulsion of right knee. And there was an open wound on the first metatarsophalangeal joint with PHL rupture. He was also having a blunt injury, abdomen and chest. This injury occurred in 2019. He was presented with some shock, hypotension, but he could resuscitated very well. So this was his AP X-ray. Shall I explain or somebody?
Yeah, it's a badly communicated even fracture in the femur as well as acetabular fracture. Would you like to go CT?
We'll go to CT. There was some fracture patella also, and there was also some bony avulsion of right knee joint. Now we'll come to some CT scan images. These are the images. You can see that there was a comminuted iliac grade.
Yeah.
Go to a PowerPoint view.
Oh, sorry. Then now, these were the coronal section images. You can see that there was a fracture of iliac grade, which is going in towards the sacroiliac joint, and there was a bicolumnar fracture there, and with the displaced quadrilateral plate. This is the magnified view of that.
It's a ABC with fracture neck femur.
Yeah. So
floating.
Accordingly, we planned the surgical tactic. We placed the patient in supine. We approach the patient with the lateral window of ilioinguinal approach, followed by AIP. First, we fixed the iliac blade as well as the fragment near the SI joint. to get the posterior base of the axial skeleton fixed, and then we proceeded with the fixation of anterior column as well as quadrilateral plate from the anterior intrapelvic approach. After the fixation of this thing, we proceeded for fracture neck femur with the help of DHS as well as CC screw. This was an AP which was taken after 2 months. The patient was very serious for about 8 to 10 days after the fixation of the surgery, and this was the oblique views of that patient after 2 months. Any comments on fixation?
It's a good fixation.
Good.
So, this was the X-ray after 1 year, and this was the X-ray after just 3 years. This is in complete follow-up, and these are
It's an excellent outcome of this very bad injury.
walking, driving.
Very good functional outcome. Very good.
Have you
Very
done
good.
your neck femur fracture closed method, or you have opened the neck?
No, we have done this by close reduction itself. Fix the fracture.
Whether you will be able to see the fracture to the fractures of the acetabular neck femur?
Pardon me, sir. What did you ask?
Yeah, I am asking you. There is so much of fractures of the acetabular. Whether you will be able to, whether you could see the fracture head of the femur, you could not see. You just managed first acetabulum and then went for the neck femur.
Sir, we first managed only acetabulum and then shifted patient on the fracture table and then fixed the fracture.
Dr. Ramesh says opinion regarding this.
And this is a very good reconstruction done both on the sides of acetabulum as well as for the neck also. It is very well, and considering the fracture pattern, I think this is the best stability achieved, where you could be assured of its stability as well as the subsequent movements also. I think this is an excellent result with the complex injury. Atul just presented those cases with such a kind of injury. These are difficult, where you need to have a good decision making and good skills also. So I think this is an excellent exposition of that ability.
Yeah, there is one more case of mine which was there, which having a floating hip with a fractured neck femur, and the head was totally dislocated posteriorly with posterior wall. So when I opened it from posterior side, the head actually I could do delivery of the head in my hand. So I had to use you have to just rotate the head, keep the head of the femur onto the neck like a cap, and then do a retrograde wiring, then put a anti-grade screws to that. So that was. Now here the things are a little bit different. So here reconstruction, the acetabulum was done first. The situation, according to the situation, we had to just manage and get the things in proper position.
Shall I continue with the second case, or I should stop sharing and then?
Yeah, we should stop here. Then we'll go to Dr. Shinde, Mrs. Tanvi Shinde.
Yeah.
And if the time permits, then we'll take another case.
Okay.
Am I audible, sir?
Yeah.
First of all, I will to thank Kothadia sir and Gadegone sir for giving me this opportunity. So I won't be taking long. So first, it's a case of a 41-year-old male. He presented with history of RTA. And these were his pre-op X-rays. This is a type T fracture involving anterior column and as well as the posterior wall extending into the posterior column. And as he was having iliac wing fracture, we also got inlet and outlet views, which shows comminuted iliac wing fracture extended into the sacroiliac joint. These are his CT scans. So there is a anterior column fracture along with a posterior wall extending into the posterior column fracture. So it's a T-type fracture. So any opinions on fixation methods?
A point which I may tell about these injuries is here it is primarily labeled as a pelvic injury. Considering that there is a posterior injury across the sacroiliac joint coming anteriorly, rather than breaking the pubic rami at a central level, it has gone much more laterally and has involved the acetabulum per se. So right now, our reduction has to start from posterior side. Once we reduce the sacroiliac joint and the ilium, then we come down to the reduction of that acetabulum. That will be the sequence which I think.
So will you do this in prone or supine?
For me, it is always a supine position because that way I can exercise reasonable amount of a reduction also. And these fractures, which we label partly as crescent fractures, we need a reduction here and a stability depending on, because it is in between. It is not out of the 3 crescent fracture, first, second, and third. It is somewhere in between. So here the anterior fragment is reasonably okay. We can get a stability across the sacroiliac joint by anterior plating. So the same approach will allow me to come down also to the acetabulum also. So because here iliopectoral eminence is also comminuted, so I'll definitely use a lateral window along with the AIP approach, with which I will be able to reduce both the injuries in this way. And for the posterior column, once the ilium is reduced, we can pass a posterior column screw which can stabilize the posterior column also.
Yes.
Actually, we
So
started.
according to you, Dr. Sen, this is a pelvic acetabulum injury rather than a pure acetabular injury.
Yes, this is
Because
primarily
it's a fracture with fracture
primarily a pelvic injury. Yes.
Actually, we started with posterior column fixation first with a retrograde screw, and then went ahead with a anterior column fixation and finally pelvic fixation. This was the immediate post-operative X-rays, and this is his 2-year follow-up. Patient is doing functionally really good.
Yeah.
As all the components of the injury have been reduced well, I think this is the reason that we could get very good result in this kind of a situation. Both the anterior column, the posterior column, as well as the pelvic part of it. So all the 3 components for the injury has been taken care of.
This is another case, a posterior fracture dislocation, a Pipkin 2 type of fracture. I think everything has been covered by Sen sir. This is just a case presentation. So this was done 4 years back. She was a 35-year-old female and history of trauma due to fall. And she had posterior dislocation with this Pipkin type 2 fracture. She presented very early, within almost 4 or 5 hours of the surgery, and we decided to intervene immediately. With posterior approach, we fixed the fracture with Herbert screw. She lives in a peripheral part of Pune, and because of the COVID, it was very difficult to get the follow-up. But I had a telephonic discussion with her, and she's doing extremely good. So that's what the case is. Thank you.
Thank you. Thank you.
Wonderful result of the first case. It's very good. And second case will have to follow for a longer period of time. What will happen to it?
She has agreed to come after COVID pandemic.
Thank you.
Now, Tanna sir, you ask, invite.
Yeah. Now I will request Dr. Tanna sir to give his views on this type of injuries. How he can enlighten us on these injuries. Dr. Tanna sir. Tanna sir.
Sir is muted.
Sorry. Apart from the views, what I'll confess is, as I said, I went on arguing with Ramesh all the time. Why the hell you are not putting the hip which is going to last for 30 years?
Yeah.
And I've been doing these cases, but I think unfortunately I have come and attended this seminar. So I think I'll have to leave these cases to be done by people like you people. You do a wonderful job. So I think now onwards I have decided.
Not able to hear you, sir.
Yes.
Yes, we can hear. Audible.
Now onwards I have decided I'm not going to touch these cases because I think all of you are doing a fantastic job, and probably I'm not suited to do it because I will do more replacement into some of these cases instead of really fixing it up and giving them a good hip. I think it is a really excellent learning for me. Beautiful cases which have been shown by different people. I have always heard Pradeep Kothadia and Ramesh and the Pune wala ka naam kya bhul gaya? Mahesh. But I think other younger people also, I have heard them for the first time. Atul, I had not heard it for the acetabular fractures, other fractures, I had heard him. Now I realize, I think the future is very, very bright for this fracture acetabular. And it is not only the Ramesh who can do it, or Pradeep who can do it, there are many more people who are doing an equally good job. Wonderful seminar, but I regret one more case, one more surgery has gone out of my hand. Thank you very much.
Thank you.
Thank you, sir. Thanks a lot for your beautiful comments, sir. Thank you. I think we are coming at the end of this seminar. I hand over it to Dr. Gadegone to say something about the seminar.
It's a wonderful seminar and the efforts put by all faculties to present their cases. And Tanna sir has kindly graced the occasion and given his expert comment. Actually, he previously said that I don't do more now with the pelviacetal procedure. I am more in favor of the joint replacement. Still, we convinced him to be the chairman of this webinar because it gives added value because his name is the star name, and therefore, thank you very much, sir, for being with us.
It was excellent.
Ramesh Sen is an international faculty. He is always with us, and he is a very humble and kind person. Whenever there is a pelviacetabular and a vascular necrosis, probably if you ask him at the 12th night also, probably he will deliver the lecture on the.
Only problem is, every time I hear Ramesh, more and more I feel, "Sala, ye hamara kaam nahi hai, hamara kaam nahi, hamara kaam nahi."
So
lovely, Ramesh. Absolutely.
Thank you, sir. Thank you, sir.
Generation
Blessings, sir.
Atul, Mahesh, Nitin, Vijayanand, Milind, and everybody, they cooperated very nicely, and probably will have a better seminar in the future. And Pradeep Kothadia, my friend,
इससे better क्या कर सकता है?
और नए cases ला सकते हैं.
This was a terrific seminar, right? Terrific.
So Pradeep Bhau, you have done a wonderful job, and I think it's a wonderful seminar. And thank you very much. And we will see you again on the 16th webinar on Masterclass, where again Tanna sir will have to come and grace the occasion. Thank you very much. Thank you.
Thank you, everybody. Thank you for coming.
Thank you, sir.
Thank you.
Thanks all.
Thank you, sir.
Neeraj and Ashok Sham, and we have to thank them also. That is important thing.
Without them, we cannot do any seminars.
They are the keys for any.
So,
Chalo, bye.
Okay. Bye, sir.
Bye.
Ramesh Sen, sir, thank you very much.
Thank you.
Thank you, sir.
Thank you. प्रदीप सर.
Yes.
सुधांशु बरा आहे का?
सुधांशु छान आहे, एकदम मस्त आहे.
सांगा सर त्याला आठवण काढली म्हणून.
हो, सांगतो. बाकी कसं काय, सगळं ठीक आहे ना?
मजेत सर.
ओके, चल. ओके.
थँक्यू.
ओके. बाय. गुड नाईट. हो गए. Hello.